Okay, so it is 11 o'clock. Let's start this webinar. Thank you everyone for joining this webinar. This webinar is brought to you by Open Silicon Valley. I'm Dr. Uruj Imtiaz, and I'm a medical director at a biotech called Ivermectin. Let me go over a few housekeeping items first. Please mute your line. Please type your questions in the chat window. This webinar is also live on Facebook, and you can type your questions there as well. The last 15 minutes of the webinar will be to answer your questions. We are thrilled that our guest today is Dr. Adeel Butt. Dr. Butt is currently a professor of medicine and professor of healthcare policy and research at Cornell Medical College in New York and Qatar. A graduate of the Khan University and University of Pittsburgh School of Medicine, Professor Butt completed his residency in internal medicine and a fellowship in infectious diseases in the US. Over the past 20 years, Dr. Butt has held numerous senior academic positions. He has published over 150 papers in high-impact medical journals, presented over 145 abstracts at major international conferences, and has mentored numerous young physicians and researchers who now hold key positions in academia. Unfortunately, as all of us know, we are in the middle of challenging times due to this pandemic caused by a novel coronavirus referred to as COVID-19, which has impacted everyone around the world. As we navigate our lives around the new normal of social distancing, remote working, and homeschooling, one of the important, and in my opinion, one of the biggest challenges we face is not enough quality information around the virus. So today, Dr. Butt is going to go over the epidemiology, treatment updates, and myth busting surrounding the COVID-19. On behalf of Open Silicon Valley, I welcome Professor Adeel Butt. Dr. Butt, over to you. Dr. Butt, I think you're on mute right now.
My apologies.
No worries. Now we can hear you great. Thank you.
And let me know when you can see my screen so I can start at that point in time.
Yes, we can now.
Okay. So first of all, I would like to thank you and your board and Open for giving me this opportunity to speak with your membership and other people who are dialing in. As you have mentioned that this pandemic has taken over our lives, and part of the issue that we are facing, as you very rightly pointed out, is a plethora of information, much of which is not curated and not fact-checked. So what we are going to do today is we are going to go over brief history of coronaviruses and epidemiology of the current outbreak. That is just to give you an idea of where we started from and where we are going with this disease. Then we'll spend a fair amount of time doing the fact or fiction game, trying to bust some of the myths that are doing the rounds on social media. We'll spend some time on new treatments that have come out, and we'll discuss some scientific evidence regarding that. And we will round it off by discussing a little bit about how to diagnose and, most importantly, how to prevent this infection from spreading. So many of you may know that coronaviruses are not new to humans. Beta coronaviruses, to which the current COVID-19 causative agent SARS-CoV-2 belongs, the family has been known to humans for quite some time. 7 species have been identified which infect humans. 4 of them are associated with mild symptoms, and they have not even been given names. They just are identified by certain numbers which identify them in the phylogenetic tree. 3 of them have gained more notoriety. SARS-CoV and MERS-CoV may be well known to most of you. And now, of course, SARS-CoV-2, which causes COVID-19, is talk of the town, so to speak. SARS, as you may recall, started in late 2002. And by the time the epidemic was over, about 8,098 people had been infected worldwide, of which 774 died. But by late July 2003, no new cases were being reported, and WHO declared that this outbreak is over. MERS-CoV started in Kingdom of Saudi Arabia in about 2013-14 period. And to date, about 2,500 cases have been reported with 858 deaths. Sporadic cases of MERS-CoV are still occurring. And I saw a case about 3 months ago in Qatar after a break of about 2 years or so. I had investigated the full outbreak in UAE in 2014. And then it had died down. We were seeing maybe one case every few months, and then it went away for a couple of years, and then it surfaced again. And the reason I'm mentioning that is that since they belong to the same family of viruses, some of the behavior of these viruses may be similar. And we may expect some of these things to happen in the future. SARS-CoV-2, as I said, is the 7th coronavirus known to infect humans. I won't go into the details of its molecular structure and so forth, because I don't believe this is a medical group. It's more of a non-medical group. But suffice it to say that genetic sequencing of the virus has been done. And through elegant studies, it has been irrefutably shown that this is a virus that evolved naturally in animals and then jumped over into humans. So one of the myths we're going to talk about that is whether it was created in a laboratory or whether it evolved naturally. And I've already mentioned the nomenclature of this virus or this disease, that SARS-CoV-2 is the name given to the causative organism, the virus that causes the disease, which we now call COVID-19, which stands for coronavirus disease. And the number 19 stands for the fact that it was the first cases were reported in 2019. The question obviously arises, how did this virus enter the human population? Because coronaviruses are very well known to infect animals. So there are two possible scenarios. One is that there was natural selection of the virus over a period of time when it mutated and became more efficient in becoming an animal pathogen, and then a critical mass of animals were infected, and then a jump over into humans occurred. The other possibility is that the natural selection in humans may have occurred early, but we never knew because it never caused disease. It did not have the genetic properties to cause disease in humans. But again, evolution occurred, and at some point in time, it developed certain mutations that started or made it efficient to cause human disease. Again, this is a bit of a molecular structure and mechanism of how it causes disease. Instead of going into the detail, just remember that it binds to certain receptors in the human lungs, but it can also bind to receptors in other parts, other organs of the body, for example, kidney. But disease is primarily in the lungs. So it enters the lung cells where it takes over the cell, it multiplies in the human cells, and then it breaks free and infects more cells and so forth. And that is the life cycle within the humans. The first cases of COVID-19, now what we know to be COVID-19, were discovered or reported in first week of December in Wuhan, China. So there were very astute physicians in Wuhan who were veterans of the previous SARS epidemic a few years ago. So they picked up a new kind of lung disease happening without any known pathology or known cause. They alerted the authorities, and within a few weeks, by the end of December, you can see in this epidemiology graph out here, by the end of December, they had already declared it to be an outbreak, meaning major mobilization had occurred within the government and in the health authorities in China. And by the end of about 6 to 8 weeks, which is the end of January or second to third week of January, not only had they closed off the market and the city and large areas where the infection was occurring, they had identified the virus, the causative agent. They had done a full genome sequencing of this virus and shared it with the rest of the world. So this is unprecedented. So a lot of media attention has been given to the fact that Chinese acted too late or too little, they did not share information, and so on and so forth. But this graph clearly shows that they not only acted very quickly, they also shared the data very rapidly with the rest of the world. It is unheard of in human history or history of infectious diseases, that you identify a novel agent within 3 to 4 weeks of the first case occurring, and then you sequence the whole virus and share it with the rest of the world as an open sequence. In other words, they did not ask for anything. They shared it as a public information for whoever wanted to do any research. And again, I'm pointing all this out. One is to bust some of those myths about Chinese acting slowly, but also to learn from this thing, that what we could have learned from how the Chinese reacted and where our missed opportunities were. So this is a global situation report of where we stand right now. We, as of about an hour or so ago, we have more than 1.8 million cases worldwide. And I can assure you, if you look at it now, the number would have increased because it is increasing by the minute. And we have had 112,000 plus deaths so far. Now, USA, we weren't number one for quite some time in this epidemic, but this is our road to becoming number one. Very soon, or a few weeks after the first case was seen in the US, our curve of infection, or the number of people being diagnosed, the cumulative number of people infected in the US, took an exponential increase or an exponential turn upwards. And we broke away from the rest of the world. And again, this comes back to the fact of missed opportunities, which we need to talk about. And we still may have some ground to cover, but there may be an opportunity somewhere in there based on other countries' experiences to do something. This is again another way of looking at this infection. In this graph, I have put together the number of new cases diagnosed per day. And on your left, where I say mostly China, these are almost exclusively infections diagnosed in China. Then there was a period where Chinese infections, or number of new cases being diagnosed in China, went down very, very rapidly. And again, you can see the timeline. This happened within about 6 to 8 weeks of first case being diagnosed. And here is, in the middle, is where there were lost opportunities or missed opportunities, where we did not act upon it, and suddenly the exponential growth or exponential increase in number of cases per day occurred and has led to where we are today. I put together this to give you a comparison of the number of daily new cases being diagnosed in 3 top countries right now. And I put Pakistan in there because a lot of our audience is from Pakistan today. So USA being number one, there is an exponential rise that is seen out here between March 16th and end of March. And the very positive or very good sign that we see is slight flattening of this curve. You see that in Italy and Spain as well, that their numbers went up exponentially and the numbers started to drop. And there may be slight trend towards going downward over a period of time. And you see that in Spain as well. Again, this is a very good sign. This is a very optimistic sign that we may have peaked in terms of the epidemic, at least in certain areas of the world. May not be all areas of the world, but at least certain areas of the world we may have peaked. Now I'm going to come back to this at the end of the talk and talk a little bit more about that. And in Pakistan, the situation is a little less clear. I've been monitoring that very closely and talking to people, the Infectious Disease Society of Pakistan, very regularly, and to some people in the government as well. The problem is that we have not done enough testing in Pakistan to have a very good picture of what's going on at a national level. So there are sporadic outbreaks where the government or hospitals or people go in and do investigation outbreaks, and they diagnose cases, but there's not a concerted effort of doing a large-scale testing, which will give us an overall picture for the country. I'm going to skip the number of deaths slides and go straight to the fact and fiction game. So when I scour or when I go over social media posts on various sites, there are things that are being perpetuated where we are having a lot of difficulty trying to dispel some of these things. And the reason this is important is that if you subscribe to some of those things, they may actually be harmful to you, to people around you, or perhaps to the population in general. So we need to set the record straight out here. So the first question or that comes up, or the first myth that is going on around, which was particularly rampant in the earlier part of the epidemic, was that COVID-19 is just like the regular flu. So what's the big deal about that? Well, the big deal about that is COVID-19 is more infectious than the regular influenza virus, and it is more lethal. However, compared to other novel coronaviruses like SARS and MERS-CoV, it is less lethal. And why do I say that? What is the evidence to support that? So here I've compiled the number of cases, number of fatalities, the number of countries infected with these 4 major causes of influenza, comparing with SARS, MERS, and COVID-19. You can see while the influenza numbers have been very high, but the number of deaths or the proportion of people who die from influenza is only a fraction of what we see with COVID-19. So generally we see somewhere between 0.05 and 0.1% mortality with influenza. With COVID-19, we have seen somewhere between 2 to 5%, depending on which country you look at. So that is an order of magnitude higher than influenza. Younger people always feel they're invincible. There's another myth going on around that because I'm young and otherwise healthy, meaning I do not have any chronic comorbidities or other chronic medical conditions, I don't have anything to fear and I can do whatever I want to. And we have seen videos of people reveling on beaches in Florida, going for spring break and so on and so forth. This is quite false. And the reason I say that is, while it is true that more serious disease occurs in people who are older, young are not immune. We have seen enough mortality in younger people to be worried about our younger generation. Even more important than that is younger people, because they have less severe disease as a group, they may have lesser symptoms, but they become very important carriers of infection and transmitters of infection. So that is something we need to keep in mind. And what is the evidence to show that young people are not spared? Again, I compiled death rates in various age groups by deciles of life. So up till the age of 40 or so, the death rate or fatality rate from COVID-19 is relatively low. There's no doubt about that, but it is still higher than influenza, which was 0.05 to 0.1% or so. So this is about twice that, even in the younger people. Influenza in the young people in this age group, there's hardly any death at all, even less than 0.05% or so. But once you cross 50, and particularly when you cross 60, the rate starts to go up. The next thing that people are perpetuating is that, oh, well, the vaccine is around the corner. And unfortunately, some people very high up in our government have touted that as well in the US, that the vaccine is going to be there, it'll take care of everything. Unfortunately, the vaccine is not very close to marketing. The trials for vaccines have started, patients have been enrolled, but to get a safe, effective, and viable vaccine to market is a long process, both in terms of determining its safety and efficacy and getting over all the regulatory issues that we need to. And then, of course, production of the vaccine and delivering it to where it needs to be. So we think that it's about 12 months or so away in our best estimate. If we get over the regulatory hurdles quicker, it may be slightly shorter, but it is definitely not around 1 or 2 months away from right now. Another thing that is doing social media rounds is that you can protect yourself by gargling with warm water or hot water, or if you take steam, or if you take salt water gargles, or if you blow hot air into your sinuses or nose or mouth, for example, with a hair dryer, it will kill the virus and it will not let the virus go in. This is not only false, it is actually quite dangerous because you can hurt yourself with some of those heat devices and so forth. While salt water gargling may have some benefit in providing symptomatic relief, and we encourage that, that goes for taking steam inhalation as well, it does nothing to the virus. It does not kill the virus. The temperature of the steam that we inhale, where it needs to work, the temperature is not high enough to kill the virus. So this is not really a true statement. Unfortunately, again, some very so-called educated and well-placed people, even in Pakistan, have started perpetuating this myth about COVID-19 and SARS-CoV-2 being created in a lab and released by certain governments. This is patently false. And I say that because there is no evidence towards that. The reports of a doctor in Boston from one of the Harvard hospitals having some ties with China, who has been indicted for some irregularities, is being provided as evidence to that. But remember, not a single report or the indictment report of this doctor mentions COVID-19 or SARS-2. The doctor apparently took some payments for some other work which had nothing to do with influenza or coronaviruses. Also, a very elegantly done genetic sequencing study and genetic marker study has shown that this virus evolved within animals as a natural evolutionary process and was not created in the lab, because the signals or the markers on the virus would be different if it was created in a lab. We also keep hearing that, well, the summer is around the corner and the virus is just going to suddenly disappear. This is probably untrue. And the reason we say that is we do know that most respiratory viruses are seasonal, but they are seasonal not because of the season itself or the ambient temperature. Influenza, for example, is more common in winter months, but that is because of lower humidity, which helps it survive longer. But even more importantly, the close gathering of humans in winter months and in cold temperatures. So when people are huddled together in close quarters, the rate of transmission is higher. So far, COVID-19 has been reported from over 203 countries and territories, many of them in the Southern Hemisphere. Many of them have had summer when this epidemic started. So we don't see any evidence otherwise to that. Next myth is that spraying whole body or streets with alcohol, chlorine, or just water will eliminate the virus. And maybe you have seen some of those tunnels that, or those tents that people have built in Pakistan and other places. You walk through that and a jet or a spray of something is sprayed onto you, and you come out very happy on the other end, feeling that you have nothing to fear about. And this is also a very dangerous myth, because first of all, it will not kill the virus that is already in your body. These chemicals, if you're using chemicals, they can actually cause severe skin and mucosal irritation, particularly eyes. So you have to be very careful around that. Also, it is impossible to cover every part of your body, every inch of your clothing that you're wearing with those sprays, unless you are dipped, doused, and scrubbed yourself in those solutions. You will not get to every part of your body. And same is true for streets and surfaces, that while we do advocate cleaning surfaces in your offices, like your desktops and tabletops, etc., but in the streets, when you spray them, it will again not cover every part of the street, so that doesn't really help you much. Next, or the final one that I'm going to talk about today, is that the countries with the high BCG vaccination rate are the ones that have the lowest rate, and somehow they're protected. So on surface, it may appear to be so, but I updated this table that I'm showing on this right here, literally about 15 minutes before I started this talk. It seems that it is not the BCG rate or proportion of people who are covered with BCG vaccination that is a driving force, but it is the number of tests done per million population that is the bigger determinant of how many cases you're going to see. Now, you may also recognize from this table and from your own readings and so forth that countries where BCG vaccination is mandatory and penetration is high are also the countries which are low and middle income countries in Africa, South America, and the subcontinent. And these are precisely the ones that have very low testing rate as of now. So because they have tested a smaller proportion of the population, the number of cases in those countries is also lower. So we, and I'm sure my team and many other teams are actually trying to look at it in much more scientific manner to see if there's a correlation that exists between BCG vaccination rate after you adjust for testing rates in each country. Moving on to how does the virus spread? And this is one of the very common questions in every talk that I give, that does the virus survive on various surfaces and how long does it survive for? There are elegant studies for some surfaces, and I've shown you one of the more recent ones. On copper surfaces, it can survive up to 4 hours at a minimum. On cardboard, up to at least up to 1 day. On plastic and stainless steel for up to 3 days or even more. Now, we've also seen that it survives in aerosols. What do I mean by that? When you sneeze or cough, you generate a spray of saliva, which is very fine and cannot be seen by the eye, but it's microscopic. So this aerosol has the virus suspended in it, and it can survive in that aerosol for up to 3 hours. Why is this important? It is important because you may walk into a room where an infected person sneezed or coughed, and this aerosol may be suspended, and it can stay suspended for 2-3 hours or so after a person has left the room, and you may inhale that. That is one of the reasons why some people started suggesting that the virus may be transmitted by the airborne route. There is no evidence otherwise that it is spread by the airborne route, but by droplets. And the biggest way of spread is someone who coughs or sneezes and then touches the surface or sneezes or coughs on a surface. The virus stays there, someone else comes in, next person comes in, touches that surface with their hand and put their hand on their mouth or their nose, and that is how the virus is being transmitted. We have also seen an alarming trend that a fair proportion of people who have no symptoms, and we'll go over what the symptoms are in the next few slides, asymptomatic people have also been known to transmit the disease. And as we progress through this pandemic, we are seeing more and more of that. Now it is being suggested that about 1/4 of the infections may be transmitted by people who are asymptomatic. That is why it is so important to adhere to those social distancing measures and quarantine measures that we're talking about. And again, we'll have some time to discuss that. This is not healthcare workers talk, but I just put in this slide, left this slide in there to give you an idea of the risk that healthcare workers face and what are the risk factors or factors that are associated with that. More and more doctors and nurses are being infected and dying at the front lines. Italy had more than 100 deaths in doctors. They crossed a mark very recently. One of the biggest factors that the doctors or nurses get infected is because of improper personal protective equipment. And this is something that should never happen, particularly in a country like ours. We're supposed to be the richest country, the most technologically advanced country, and supposed to be the best prepared country in the world. It should not happen, but it is happening. And this is a major factor for healthcare workers picking up the infection. Another question that is very, very commonly asked, and there is a very reinvigoration of this debate about wearing masks by the general public. So initially we were discouraging that or not supporting that. And the reason for that is if the rate of infection is relatively low in a community or in a country, the masks do not offer any significant protection for the masses. But once you cross a certain inflection point or a point of no return, or so to speak, then the returns on wearing masks increase. And I think we have reached that number or that critical point in most countries that we are advocating wearing some sort of a mask when you go out. First of all, people shouldn't go out unless it is absolutely critical. But if you have to go out for groceries or picking up your medicines and so forth, or some other critical task, it is okay, and we encourage you to wear surgical masks or even a cloth mask that you have fashioned at home. Now, one thing that you have to be very careful about is don't get complacent and overly confident that if I'm wearing a mask, I can do whatever else I want to do. Remember, you may still have the virus being sprayed onto the outer surface of your mask, whatever mask you're wearing, surgical or even N95 or the medical mask or a cloth mask you're fashioned. So if you touch the outer surface of the mask after going out and touching other surfaces, you may still transmit the virus to that mask's outer surface. And then if you do not wash your hands and touch your face or nose, you will get that infection and you will transmit that infection. The lesson here is twofold. Yes, do wear the masks, but do not forego all the other hygiene measures, particularly meticulous hand washing that we've been advocating so much lately. So masks are not a substitute for hand washing and hand hygiene and proper cough etiquette and so forth. It is not a substitute. It may be somewhat complementary, but certainly you need to take care of the other things as well. The other thing to remember is that masks are better for if you have the infection to prevent others from getting it from you. They're less effective if you go out in a mask as an asymptomatic, uninfected person to prevent you from getting it. There is probably some protection, but the better use of the mask is of people who are symptomatic from transmitting it to other people. How does the disease present? The most common symptom is fever. So at the time of presentation to a hospital or doctor, at the time you get infected, only about half the people have fever. But during the course, over the next few days, about 90 to 98% of the people will have fever. And fever is defined as temperature of more than 38 degrees centigrade, some say 38.5 Celsius, which corresponds roughly to 100.4 or 101. But fever is one of the most common things and is the most consistent thing. Cough, which is generally dry, is seen about 2/3 of the cases, not in all people, but about 2/3 of the cases. All the rest of the symptoms are seen in 1/3 or less of the people. For example, fatigue, sputum production, shortness of breath, muscle pains and joint pains, sore throat, headache. We've also seen diarrhea in a small number of people. And actually we have isolated the virus from stool specimen as well. So we are looking into into whether the infection can be transmitted through that route or not. We don't know that yet, but the virus certainly can be isolated from the stool. People who develop more severe disease are more likely to have cough. So if you look at it the other way, if you do have high fever and a cough, then you're more likely to progress on to developing more severe disease like the actual pneumonia. And these people will have chest X-ray abnormalities. And these are people who generally have other medical problems like high blood pressure, diabetes, heart disease, liver disease, and so forth. And if you have all these symptoms, if you have pneumonia diagnosed, then your chance of developing severe lung injury or acute respiratory distress syndrome, ARDS, is close to 50% or so. 1/4 of these people will need admission to the intensive care unit, and about 1/5 of these people will die. Now, I'm going to simplify this slide by just giving you the risk factors for more severe disease. So this is kind of the sum of the previous complicated slide. Who are the people who are at most risk for severe disease? These are people who are older, more than 65 years old generally, or 60 years old. People who have other medical conditions like diabetes, high blood pressure, chronic kidney disease, chronic lung disease like asthma or emphysema, chronic liver disease, and any reason to have low immunity. For example, people who are on immunosuppressive drugs for rheumatic diseases, for rheumatoid arthritis, lupus, etc. People who have had transplants and are on anti-transplant rejection drugs. All these people are at high risk of developing more severe disease and complications of this disease. How do you diagnose? Again, this slide is more for healthcare workers, but maybe of some use if someone you know is being worked up. The way to diagnose, the most common way that we're using right now is a nasopharyngeal swab. In other words, we take a special Q-tip sort of swab. We put it in the nose as far back as possible, and then we send it to the lab for testing by nucleic acid amplification. Low respiratory secretions, for example, if you put a tube down someone's lungs and take washings from deep inside your lungs, are much better at diagnosing the disease. However, we do not recommend that for 2 reasons. One, this is a much more invasive test and the certain degree of complications associated with that. Equally importantly, it is a very high risk procedure for giving infection or transmitting infection to people who are doing these procedures. So unless there's a real need to do that, we don't advocate that. We just go by nasopharyngeal swabs, which are positive in about 2/3, about 63 to 68% of the cases. So there's still what we call false negatives. We may miss certain people. We may need to test a second time and occasionally a third time if the suspicion is very high, but at least it cuts down the risk to people around them. Other tests, some of these have actually been developed. Serology, or your body's response by measuring antibodies. The test is there. It is much more rapid. It can be done at point of care. The result can come back in about 30 to 45 minutes. Some of these tests are almost like the pregnancy test that we know of, that you can take a drop of blood, put it on a strip, and in about 20, 30, or 40 minutes or so, it'll show you whether you have antibodies to the virus or not. The downside of serology tests is that these tests become positive only about 5 to 7 days after you have been infected. They're not positive very early on in the infection, which is when we still need to do nasopharyngeal or respiratory swabs to do that. So how do you treat COVID-19? And let me go back to this slide. Maybe some people would like to know the course of disease in people if people are not treated and so forth. So if you measure quantitatively the amount of virus in the nasopharyngeal secretions or saliva or blood, it decreases over a period of 5 to 7 days or so. So you get infected, the quantitative amount of virus is very high in your secretions from the nose, in your sputum and your lung secretions. But even without treatment, about somewhere between 60 to 80% of the people will start having a decline in this, what we call viral load, over a period of first week to 10 days or so. And a vast majority of people, about 80 to 85% of the people will recover without requiring any significant intervention. A smaller proportion of people, about 12 to 15%, will have severe enough disease or pneumonia that they will require hospitalization, but not in the ICU. And about 3 to 5% of overall people infected will require hospitalization in an intensive care unit. And these are the people who are the sickest, who have comorbidities or other medical conditions. And these are the ones who have very, very high mortality. So if you end up in the ICU, requiring ICU care and go on and require being on a ventilator, then your mortality rate goes up to about 50% or so. How do you treat that? So there is no approved drug as of now, no matter what people tell you. Let me repeat that. There is no approved drug for COVID-19 and SARS-CoV-2, no matter what people tell you and what you read on social media. On 30th of March, FDA did issue what we call an emergency use authorization for chloroquine and hydroxychloroquine, which are anti-malaria drugs, for certain patients with COVID-19 infection. However, this authorization did not include prophylaxis, and FDA then afterwards revised this statement to say that that this is not a well-proven therapy. This can be used as for compassionate use in a proportion of people and has to be used very carefully because the drug is not benign. It has very severe, significant side effects in a small proportion of people. In the absence of that, treatment is largely supportive. But I'll go over some of the trials of some promising drugs that are out in clinical trials right now. Let me start by what does not work. I already mentioned that saltwater gargles, hot water, steam, blow drying your nose, all these things do not work. Gargling with steam, gargling with acetic acid, etc., does not work and may actually be harmful. And this Peer Saab, I was fascinated to see his video. He was so confident. Kabutar ke pote ki jhilli, which in other words is the lining of the stomach of a pigeon, is the ultimate treatment for COVID-19. I don't know how he even came up with that. I mean, I'm amazed how he came up with such precise treatment that no one else could have thought of. In India, you may have seen Gau Mutar being touted as the treatment for everything. I saw this. I think this is someone from the Kharbuza Mafia who just wanted to sell more kharbuzas, probably. So none of these are known to have any effect against the coronaviruses. What are the drugs that have a possible role? So chloroquine and azithromycin combination. Again, chloroquine is an anti-malaria drug. Azithromycin is an antibiotic often used for treatment of mild to moderate pneumonia. This combination has been shown in uncontrolled, poorly done trials to have some benefit. Larger trials are in the works, which are better designed and have controlled arms as well. The earlier reports are from very poorly designed observational studies. In other words, someone saw a benefit in a certain number of patients they treated. There was no comparison group, and they published that, and everyone jumped on the bandwagon, including our president. We have had a small report of convalescent plasma or serum being effective. So convalescent plasma is a blood component taken from people who were infected and are now healed, and they have presumably developed antibodies, and when injected into an uninfected person may be protective. Remdesivir is an antiviral drug which has shown some promise. I'll show the result of the clinical trial that has led to that. And a group of drugs called IL-6 receptor blockers, generally used for treatment of rheumatic diseases like rheumatoid arthritis and lupus and Crohn's disease and so forth. These have been shown to be effective in a small subset of patients who have very severe disease. More recently, an antiparasitic drug, Ivermectin, has shown some promise, but only in 1 or 2 small clinical trials. Drugs that don't have any role are steroids, ACE inhibitors, which are commonly used for blood pressure and heart conditions, the anti-influenza drug oseltamivir, and the anti-HIV drug combination called lopinavir-ritonavir. These drugs should be used only if there's another reason to use that, but they have not had any effect on the coronaviruses. And I'll very quickly go through the evidence for some of these drugs. I'll be happy to take questions on these later on, because again, my feeling is this is not a talk to healthcare providers and mostly. This is the clinical trial that started all the hype about chloroquine and hydroxychloroquine. It was a trial in which only 20 people were treated with hydroxychloroquine and azithromycin. They also got a whole boatload of other things which you don't even know about, antivirals, antibiotics, etc. There was no proper control group, so to speak, and people had varying severity of disease. I showed you the viral kinetics graph where viral load goes down even when you don't give any treatment. So it is unclear if these people, the green line out here, they would have developed or cleared the virus even without treatment, or was it really the treatment that helped? The same group from France published a follow-up of this study, which was published a couple of weeks ago. This time they had 80 patients, but same concerns, very significant concerns, that there was no control group. There were a mix of patients with all sorts of disease severity. And even when people did not get treated, even when people had no severe disease, very mild disease, they had no difference in their outcomes. So concerns again are, they lumped together people with very severe disease along with people with very mild disease, and people with very severe disease was a very, very small proportion, less than 5% of the people. So it is unclear that if you take 95% of the people in your study are otherwise relatively healthy and have very, very mild disease, they probably would have gotten better even without treatment. This is a trial with remdesivir, which was published actually about 3 days ago. And it shows promise. Is an antiviral drug, which shows that about 60 to 65% of the people who were given this treatment had improvement in general improvement in symptoms, or clinical severity of the disease was lower. This was a moderately well done trial, not the best of trials, because everyone is trying all these treatments on a compassionate use basis, meaning when people are sick, they just want to give something for the sake of giving because they don't have anything else. But it has shown promise, and larger, better designed clinical trials are in the works. I talked about convalescent serum. This is the study on which this is based. only 5 people, no control arm. They received other treatments as well. Now, we also used this treatment for SARS in 2002-03, and we also used this for MERS coronavirus a few years ago with very mixed and not too encouraging results. There is a group of scientists and doctors around the world who swear by the efficacy of this, but we haven't seen strong enough data to advocate it on a very widespread basis. Ivermectin, which is an antiparasitic drug widely used in the world, has shown that it can reduce the virus in cell cultures by about 5,000-fold. Now, this is a lab study, not a human study. So we are waiting for some trials in humans to see that if this actually can be translated into humans and in disease conditions that affect humans. Tocilizumab, which again is an IL-6 blocker, this is the study that has generated interest, and this has some biologic plausibility as well. A small number of people who are in the ICU develop what we call an interleukin storm or an inflammatory marker storm. They develop very high levels of inflammatory markers, and this is an inflammation blocker. So people have hypothesized that if you block that inflammation or inflammatory marker from being produced, you will have a better result. And in a small number of people, it did show some benefit, and larger clinical trials are ongoing. Now, I do realize that I keep saying that we don't have enough data, but this is a new disease, and it does take a little while to do decent clinical trials to figure out what's going on, what is effective, what is not effective, and equally importantly, what is safe and what is unsafe. Lopinavir-ritonavir, which is an anti-HIV drug combination, has not been shown to be effective, so it should be taken off the table in these patients. This is a triage algorithm, again, more for hospital people. So I won't go into the details of that, except saying that the way we triage people is based on their symptomatology. Ideally, we should isolate every single person, and we should, if we had treatment, we should treat every single person. But because of logistic limitations, we have to triage people to those who have mild or no symptoms and those who have moderate or severe symptoms. The latter two groups need to be admitted to the hospital. The severe, most people, of course, need to be in the ICU and so forth. Those who have no symptoms or very mild symptoms can be managed either in home quarantine, or if that is not possible, which is true for many countries, they should be in institutional quarantine facilities. How do you prevent that? So there are two parts of preventing this from spreading, and unfortunately, we have lost the game in many countries already. First part of this is you prevent yourself from getting it. The second part of it is, if God forbid you have it, you should stop the cycle of transmission. And these two go hand in hand. And if we do that, that is how we save the world and break the chain. And what are the steps needed to break the cycle? I think you have heard this over and over and over again. Social distancing, meaning no handshakes, no hugs. Stay away from gatherings, avoid malls, restaurants, weddings, funerals, mosques, churches, etc. Wherever there is a chance of, wherever there is a large gathering of people from different areas, you should avoid that at this point in time. Supplement that with the meticulous hand hygiene, frequent hand washing, which is 20 minutes of washing with soap, thorough washing with soap, or sanitization of your hands with an alcohol-based sanitizer, which has at least 60% alcohol in it. We strongly recommend restricting travel significantly, including targeted lockdowns or targeted curfews in certain areas which are hotbeds of infection, where infection is spreading very, very rapidly. This has been shown in many countries to be highly effective in preventing the outbreak from becoming very, very large, unlike the US, where it is just totally out of control. Management of contacts is based on a quick medical evaluation. If there is a contact with a confirmed case, then we immediately isolate the person and test them. Further management is based on case definition and presence of symptoms, as I showed you in one of the previous slides. If you have a contact of a contact who is asymptomatic, in other words, someone comes to you and say that, well, I came into contact with someone who came into contact with someone, we don't recommend any specific targeted measures for these people, except the general measures of social distancing, home isolation or home quarantine, and basic hygienic principles like meticulous hand washing. The same thing can be extended to your workplace, that whenever possible, work from home. Don't go to work your offices if you can avoid it. We, unfortunately, at the front lines have to be in the hospital, in our offices for about 12 to 14 hours a day these days. That is, for us, is unavoidable, but many others can work from home. And if you have that opportunity, please do so. If you have to go, then do not gather in large numbers in any places. Stay in your office, clean the desk, your desk with the anti-infective wipes as much as possible. So this is the second last slide, and this addresses the question that I always get: when is it going to end? Is there any end in sight? And this actually is a few days old slide. I should have updated that, but the previous slide that showed is an updated one, which shows a flattening of the curve even in the US for about 4 or 5 days or so. So that is a very, very optimistic sign that if we strictly follow or adhere to isolation measures and targeted lockdowns and staying at home, we still have a window of opportunity to control it. Spain and Italy have done it. They also started late, but they did not delay it as much as we have done in the US. They did not delay it as much as the US has delayed it. So they have seen the curve flattening a little earlier in terms of the timeline than we have. So this I take to be the light at the end of the tunnel, that we still have an opportunity to not have this infection become like what the 1918 Spanish flu was, which wiped out about a third or quarter of the world's population. So I'll stop here with this summary that this pandemic is on the upswing in certain parts of the world. China and now Western Europe has started to manage it relatively well. And that has been because of strict public health measures. Those who denied public health measures, like Italy and the UK, saw a very frightening surge of cases. But once they reverted to those measures, they fortunately, after about a gap of 4 weeks or so, 3 to 4 weeks gap, they started to see the curve to flatten. It hasn't started going down in a very predictable manner, but at least it has plateaued. Public has to take responsibility. We can't be going out to parties, clubbing, and so forth, or tablighi jamaat, or churches, or mosques, or funerals, and expect that nothing is going to happen. While the governments must provide a unified and clear advice, which has been lacking for us, and they should enforce it as well, we need to do our part of staying at home. Chinese did that, Koreans did that, Japanese did that as well. Their populations, their public did that as a community responsibility thing, and they controlled the epidemics very quickly. So I will stop here, Uruj. I'll hand it back to you, and I'll be happy to take any questions. Let me figure out how to give this control back to you.
Thank you so much, Dr. Butt. That was an extremely helpful talk. We did receive quite a few questions. Before we get to the questions received by our attendees, just a couple of questions that I had. Any comment on the mutagenesis of the virus? You know, viruses are known to mutate, and they're always a step behind, and they're always a step ahead of us in terms of research. Any comments? Is that mutated? Do we expect it to change? Is there going to be a second peak from another type of virus? Just a few comments, and then I will jump into the questions that we received.
Yeah. So coronaviruses are not known to be highly mutating viruses based on our experience with the previous 6 viruses. So they have generally preserved sequences over a period of time. Now we have seen reports that the 2 strains which are circulating, they call the L strain and the S strain, and some of the differences in severity of illness in different countries may be explained by that. One strain is much more virulent than the other strain. That may explain, but we won't have that full knowledge unless many countries start to sequence the virus and identify which strain is infecting. The corollary to that question is that if I get infected, will I develop immunity? Will I get infected again? And again, based on our knowledge of coronaviruses in general, the immunity should be long lasting. We don't know it's going to be a year or 2 years or 10 years, but generally with SARS and with MERS-CoV, we haven't seen any reinfections. There is a report or two of people getting reinfected. And now we've started to hear in the last 2-3 days or so that a larger proportion of people is coming back positive from China and Japan and Korea. We are waiting to see if they are true reinfections or they were false negatives in between and they just turned up positive when you did repeated testing.
Wonderful. And one last question that I have is, you show the mortality rate, it's pretty high as compared to influenza, as we have seen so far. But is that the true mortality rate, considering we are only looking at the patients who have been tested? And there is some studies that suggest that coronavirus might be with us for a longer period of time than we had initially thought. And you in your presentation, you had already mentioned that there are 25% of patients who might be asymptomatic and still spreading it. So any comments around what would be, we won't probably know the actual number of patients who are people who have been infected by the virus till this pandemic ends and we do a complete analysis on it. But any ideas that, we are saying it's 1.8 million people, over 1.8 million people have been infected or have been, they've shown the virus. Is that more, or, is it 10-fold more or 5-fold more? Any comments around that?
Yeah, so it is completely unknown how many more people are infected. And you're right, the mortality number that we give is what we call crude case fatality rate. In other words, the number of cases who died divided with the number of cases who are positively identified at this point in time. However, at least one group has done more of a modeling study trying to account for all the undiagnosed cases, but this was caveated, this was much earlier in the epidemic. This was done about 1.5 months or 2 months ago. Their case fatality rate calculation was about 1.4 to 1.8% or so. So still at least 10-fold higher than influenza, but you're right. If we diagnose more and more milder cases, this case fatality rate is going to go down.
Great. So I'll jump into the questions that we have received online so far. One of the questions is that why is that in some countries it has spread more rapidly than others despite being equally densely populated?
So the population density is one factor, but population dynamics is an equally important factor. So if there were, if population was less mobile, less interactive, staying more at home, that would have been the strongest factor to curb down the spread. Beyond that, we haven't seen any other factors positively at this point in time that would explain that.
And I believe you've already mentioned that in your presentation, is the more we test, the more we find out. So there are certain countries who have been densely populated, but if you don't test, you don't know how much infection there is.
Well, to give an example, the rate of testing in Pakistan is about 20 tests per million. In India, it's a little less than that, as opposed to, for example, Qatar, which has done 10,000 tests per million, UAE, which has done about 20,000 to 30,000 tests per million. So you can't really expect that you would be picking the correct number of patients when you're doing only 20 tests per million people.
Correct. One of the question is that there was an article on use of ventilators. How safe are they?
So ventilators are safe. The problem is why you are on a ventilator. That is what the problem is. So if you're on a ventilator, it means you are extremely sick.
Right.
I mean, that is a thing of absolutely last resort. So it's not the ventilator that is dangerous. It's what got you to the ventilator is what we worry about.
Yes, absolutely. I think, as you've mentioned, it's the 5% who gets super critical and are put on ventilators. They're already in an immunocompromised condition. So, ventilators can help so much. When people go to work, how can they ensure they don't get infected?
The only way to ensure reasonably well is don't go to work from home, be in absolute isolation. if you are coming into contact with anything outside your house, there is a small potential risk of getting infected. You can never guarantee that no one has passed through the door or handled the door that you opened with infected hands before you did. And like I said, on stainless steel, which is what is often the doorknobs, the virus can live for up to 3 days.
Right.
So if 2 or 3 days ago, some of the infection on his hands touched that door, and you touch it and touch your nose, there's a risk that you will get the infection. But you can minimize that by sanitizing your hand or washing your hand repeatedly. So if you have to go to the office, you get to your office, before you ever touch anything on your, first of all, try avoiding touching your face, but get to your office, you wash your hands or sanitize your hands and do that multiple times during the day. This will significantly reduce your risk. There's nothing that would be 0%,
correct,
unfortunately.
So you've mentioned that the virus stays on the surface for quite a bit of time, as is mentioned in your presentation. Does the infectivity decrease over time? You know, if the person who has touched the whatever surface, and now 6 hours later, is the infectivity same as it was an hour before, or to 6 hours of the virus, or?
So there are no data on that. People have done viability studies of the virus, so we can tell that the virus is alive and infective, but how infective it is difficult to say. So remember, there are 3 things that determine if you will get infection or not. One is the virus's virulence, that is only one part. Second is the host susceptibility. And third is the dose that you get exposed with. So all 3 have to be taken into account, all 3 count towards that. So virus may be small in amount, but you may be very susceptible, you may pick it up. Virus may be less virulent. The opposite of that is you may have a very large amount of virus, someone deposited on a surface, and you are still relatively healthy because the amount was so large that you got it.
Right.
So it's not just one factor that would determine infectivity.
Wonderful. So any comment about the Swedish approach, which is at odds with the rest of the world, and how they have approached the virus?
I have no idea what the Swedish approach is. I've read in the newspapers about the herd immunity, let everyone get infected.
Right.
Yeah. I wouldn't want my parents or my family member to go through that.
Right.
That's my short answer.
Yeah.
So and I think Boris Johnson has gone through that in a very painful way, advocating herd immunity and then ending up in the ICU. I don't think he's advocating that anymore.
I don't think anybody is right now. So one of the questions was, in one of the slides, we saw 2 colors linked to Hunan market versus not linked to Hunan market. Can you explain that?
So the first cases that came to light were thought to be from the market, a seafood market in Hunan. But that seafood market also carried a whole bunch of other things, live animals, live seafood, live vegetables, and so forth. But very soon after, they discovered that a fair number of people had no connection to the market itself. And the theory behind that was that the market may not have been the only epicenter. By the time the first cases were identified, the market just became a red herring or a warning sign, but the cases had already been in the community and they were spreading from within the community at that point in time.
Great. I'll have 2 more questions. So one question is, if people are not being tested as much as they should be, how are we able to consider into flattening the curve that we are seeing right now?
So if there is a significant impediment to testing, like for example, in certain African countries where you just don't have either the logistics or the money to buy the tests or to run the tests, you still need to do social distancing, isolation, and what I call targeted lockdowns. I don't think a blanket curfew for the whole country is needed in most instances. We in Qatar, I've been advising the government of Qatar, the Ministry of Public Health and so forth. What we have done is targeted lockdown. So instead of locking down the whole country, where we find a pocket of spread or a case cluster, we target that area. There was one cluster that was large enough that we locked down that about 32 block area. But we haven't done the curfews like India has done, or certain other countries. Like for example, Dubai has instituted a curfew right now. So we haven't gotten to that level.
Great. And so one of the question is, a lot of people here in the US have their groceries delivered at home. Any comments about how safe are they and what methods we should take to sanitize them?
So you'll have to tell me if the person who brought them was infected or not for me to answer that, right? So since we do not know that, you have to take some common sense precautions. So I think the risk is still low to moderate. It's not high, but there's certain things you can do to decrease that risk further. For example, if they bring it in a paper bag, transfer it from that paper bag into your own sanitized, clean bag or bowl or whatever utensils you have right at the door before bringing it in. So right at the door, transfer that into what you know to be sterilized or a clean utensil or bag. And then when you bring the produce in or whatever you brought in, if it is something that is washable, you wash it with warm water for about 20 seconds or so. So you do all those common sense steps to try to decrease the risk as much as possible.
Great. I was going to say that was the last question, but we received a very interesting question I would want for you to answer.
Sure.
We saw the cases in China, in Wuhan, go really off the radar initially when the pandemic started, but not a lot of cases were detected in the other provinces of China. Any comment on why that happened and how we could have, done it in a way that would not have impacted the rest of the world too?
So, so it is not correct to say that cases are not seen in other provinces. A fair amount of cases were seen in other provinces. But I think what the Chinese government did, and the Chinese public was very cooperative in that, either under coercion or voluntarily, that's a separate debate. The initial case clusters were in Wuhan. So we think that is where it started. It did spread. If you look at the spread map, wherever the transport went, for example, buses and trains, you see a very clear line of transmission along those transportation routes. But they did a lockdown within 4 weeks. So in first week of December 2019, they found the first case. By end of December, they closed down the city. Although a fair number of people hadn't gotten out, but they tried to trace them out as well. So no, people were detected in other cities as well, but I think it's the very early and rather the word being used is draconian lockdown, which prevented spreading it from many other countries. And remember, the population of China is concentrated on the coast. As you go inland, the population density is much lower.
Wonderful, yeah. This was extremely helpful, Dr. Butt. Thank you so much for your time. Appreciate it. And where will this talk be? We can access it on our Facebook page. This talk will be posted on Open Silicon Valley, all social media. So once again, on behalf of Open, I thank you. An extremely helpful conversation. And hopefully, we're all in this together and we can come out of it as better human beings.
Absolutely.
Thank you so much. I appreciate it.
Thank you. Take care. Bye-bye.